Today, we're going to be talking about the management of alcohol-associated hepatitis, also informally known as ALC-HEP. So let's get started with the case. We have Mr. Smith, who is a 55-year-old male with severe alcohol use disorder who presents to the emergency department and is found to have alcohol-associated hepatitis. His prothrombin time is 22 and total bilirubin is 3.2. Which of the following treatments will you offer him? A. Pentoxifylline 400 milligrams 3 times a day. B. Prednisolone 40 milligrams daily for 7 days and then reevaluate. C. Prednisolone 40 milligrams daily for 28 days. Or D. Ursodiol 300 milligrams 2 times a day. To answer this question, we first need to understand the severity of his alcohol-associated hepatitis. But before we get into the severity, let's take a step back and define ALC-HEP. ALC-HEP is a manifestation of the broad category of alcohol-associated liver disease. It is usually preceded by a recent alcohol binge episode. This triggers inflammation within the liver and can manifest clinically as jaundice, abdominal pain, anorexia, malaise, hepatomegaly, SIRS, and general hepatic decompensation. To assess severity of ALC-HEP, we can use the Madry's discriminant function. This tool takes into account the patient's prothrombin time, the institution's control prothrombin time, and the patient's total bilirubin. A score of greater than 32 indicates severe ALC-HEP. If we plug in Mr. Smith's labs, we see his Madry score is 44.6, which indicates severe disease. We know severe disease indicates poor prognosis, but luckily there are validated treatments that are known to help with short-term mortality. Before we jump straight to the management of severe ALC-HEP, let's talk about the management of mild to moderate ALC-HEP. Let's say our patient score was less than 32. What would we do? The mainstay of treatment for mild or moderate disease is unfortunately just conservative therapy. Alcohol cessation is the biggest recommendation. Along with this comes treating the underlying alcohol use disorder. Hydration and nutrition are two other big pillars of treatment. For severe ALC-HEP, the management is multi-step. Firstly, you still need to consider alcohol cessation, hydration, and nutrition as you do with mild to moderate disease. But then, you need to rule out any infection with a urine culture, blood culture, chest x-ray, and acidic culture, and treat any infection if found. This is because steroids are the mainstay of treatment of severe ALC-HEP. There have been many studies to show that steroids can decrease mortality in patients with severe ALC-HEP over pentoxifylline. However, the most recent large trial, the STOPPA trial, showed that steroids have a non-significant short-term mortality benefit, but unfortunately not long-term mortality for these patients. The steroids of choice are either methylprednisolone or prednisolone daily, as these formulations do not require processing by the liver, unlike traditional prednisone. The doses are either 32 milligrams or 40 milligrams respectively. The typical course is 28 days. However, more research has shown that not all patients with severe ALC-HEP benefit from steroids, and 28 days of high-dose steroids is not a benign intervention. Thus, we can use the Lille score at day 7 of steroids to assess responsiveness to therapy and decide whether to continue the full 28-day course or stop early if the steroid therapy is not helping. The Lille score takes into account the patient's age, albumin, pre-treatment bilirubin, day 7 bilirubin, creatinine, and prothrombin time. A score of greater than 0.45 predicts about a 6-month survival of only 25%. For patients with a Lille score of greater than 0.45, continued steroid treatment is not recommended. A score of less than 0.45 predicts a 6-month survival of about 85%. So for patients with a score of less than 0.45, they should continue the full 28-day course of steroids. Before we summarize, I want to take a second to mention other medications you may have seen associated with ALC-HEP. Pentoxifylline and TNF-alpha inhibitors unfortunately lack any evidence of efficacy. There are new treatments that are being studied for ALC-HEP, including therapies targeting steatosis, inflammation, and the microbiome. So now going back to our question with Mr. Smith. With the information we learned, we know that B would be the correct answer. To review, when you admit a patient with alcohol-associated hepatitis, you should first determine severity of disease by calculating the Maddrey's discriminant function. For mild to moderate disease, focus treatment on alcohol cessation and supportive therapy. For severe ALCAP, start steroids after ruling out infection or treating any known infection. Choose 32 milligrams of methylprednisolone or 40 milligrams of prednisolone for at least 7 days. At 7 days, calculate the Lille score. If the Lille score is less than 0.45, continue therapy for 28 days. If the score is greater than 0.45, steroids are likely doing more harm than good, and stop therapy early.